My objectives today are to talk about clinical assessment and preventative health. Apparently you're going to learn all of that from me. Maybe you can teach me all of that. Basically, we want you to have an understanding of why we do assessment. You probably know that already. I'm just going to reinforce it. We want you to have an understanding of the benefits and then sort of how to do it. Also the same with preventative health, why and how. And then, so we all get to eat dinner at night, how we get paid for it, or how the clinic gets paid for it, if nothing else. So they want us to begin. What do we put in an assessment? Anyone got any suggestions? What would be our primary focus in general practice for an assessment?
Past history, family
History is a good place to start. Great.
age.
Age? What is it? What benefits are knowing someone's age?
You know what their increased risk factors are.
You get to know their risk factors. So already we're doing preventative health just as we've just started. We've been here, 5 minutes? We've already started doing some preventative health because we know what we might expect because we're looking at how old they are, what's happened to them in the past. All of these things are pretty much prescribed or very easy to find a place to put them, but you need to know how to make your clinical software so you can record this information. There's a big push at the moment for quality improvement, which are my favourite words, honest, not. But quality improvement does encompass being able to find out which bits we have and which bits we're missing so we can do more of what we do better. So I'm going to show you, there's a portal called On Demand Training. It's the Digital Health Agency have put it together, and it's a really useful place. You can go to it and find your most clinical software, so Best Practice, Medical Director, Communicare, there's EdMeds on there, and you can figure out how to use your software better to record these sorts of things. The big push for quality improvement is to put the data where the software wants it to be, so that you can then go back and review it to see, are you doing well and who have you missed? So where you can improve the quality improvement. And I have to keep saying it because they didn't give me any other words to use. So if I just pause this, not like that, there we go. And go here and then go here. You can see here I'm in best practice. And in best practice, and I'm happy to show you other softwares, and we'll probably use a different one a bit later on, there are places to put your bits you're looking for an assessment. So you can start with your past history, and there's the place to put it. If you put it in here, doing a search later on to find out what past history items are relevant to whatever your search is, the software will pick it up and give it back to you. Any software analysis tool, Polar, PenCat, or whatever it is your practice chooses to use, will then pick it up and give it back to you so you can see what data you're missing and where you need to improve. But it also means you can start to look at other things for your patients. So I strongly recommend you have a play around in this on-demand training, which looks like this when you go there. There it is, on-demand training. It's free for anyone to use. You just scroll down, as I'm going to do here, just to show you. Click on the Go to On-Demand Training. It takes a second to load, and there's your software comes up. You click on the software that you would like to have up there. We'll go Medical Director this time. There's a password you have to put in before you get to this step. It's written in on that first page. The password is here, this here. That doesn't change. So I'm now in Medical Direct, or in the Medical Director portal, and I'll be able to log on to Medical Director doing this. Again, it gives you the password to get in here and tells you which doctor to use. You can do like I'm doing, you can copy, and when it loads, goodbye, I don't like you anymore, pop in your password and then you're in. So have a play. We don't want him. Oh, yes, we do. Paste it in there, log in, and it goes in. So that's for your information to find out have a play. You can't break these things. I've tried several thousand times and they won't let me break it. It just closes and you open it again and it's all better again. It's really good. You can take screenshots if you need to show someone else how to use it. So then magically I can go back to here because I'm software literate. So there you go. So one thing I really want to promote is popping your data where it says, pop your BP in your observations list, pop your height and your weight in the same list, pop your history in the past history list. If it's a phone call, does it really need to be in history? Probably not, because I don't think anyone's ever died of a phone call. Just saying, don't think it's a history item. So have a look at your data when you're in a patient and clean those items up. Makes it much easier to find things.
Unless I was saying I've got chest pain.
On the phone call, yeah. We'd probably put chest pain, but is it a past history? Probably not. Is it an active history? Probably not, because it's not a disease, it's a chest pain. So we deal with the chest pain, we find out the cause, and we put that in as our active history, or if it's finished with, our past history, rather than chest pain, because that actually, if I go to a specialist and they say on my past history I've got chest pain, well, that's useless information. It doesn't help nobody. If it's on my health record as chest pain, that doesn't help anyone either. So they're the sorts of things we're encouraging you guys to do, and also role model that for the rest of the clinicians in the team. Anyway, back to our assessment. What is an assessment? We always assess people. I walk in the room like this, you're assessing me. As nurses, we learn to do this automatically. You're thinking there's either something wrong with her brain or her leg doesn't work properly, yeah? So we're always assessing people. What we're encouraging you to do is formalise that assessment so you can use the information to support your patients going forward. This information also helps us look at population health. So we've got a cohort of patients with COPD. We can target some of our resources to this population of COPD. We can target our education, we can target our staff education, our patient education, we can target our resources to support that population group. If in the general practice I work in, I think we've got 4 children on the books at the moment. Putting up a poster about childhood immunisation is going to be very interesting for the cohort of patients that's over 4. About 88% of the patients are over 50. They've probably not got kids that age anymore. Putting up a poster about COPD for those patients is probably going to have a lot more benefits. And there's an idea about population management. Allocating time and for you as nurses to spend with your patients assessing and monitoring their diabetes because of that patient cohort, they're more likely to have it. If I give you half a day to look after diabetes patients and you've got 2 in the practice, you're going to have a great day. I'm coming to work with you. But it's not a really wise use of your resources. So there's the other things that we need to look at when we're doing an assessment of our patients. There's also, with assessment, some guidelines for clinical requirements for managing patients, and these are the other parts of assessment. For your diabetes cycle of care, for example, there's a guideline that says that every person with diabetes will have an ECG every 12 months. Great. An ECG is part of an assessment. But if you don't know the guidelines, you don't do the assessment, then how are you knowing if there's any progressive implications of the diabetes for that particular patient? You can't support the patient without the assessment. So there's quite a lot of reasons to do an assessment on a patient. So, what do you guys already do in your practice? Do you have policies? Yeah? Every practice has a policy on assessments? Stay still. Sorry. Yeah? Do you know where your policy lives? Anyone? On the shelf above the nurse's desk? In the cupboard that's in the practice management's office? But she's only there on Tuesdays and Thursdays, so if you want it any other day of the week, you're stuck. Do we all know if we have a policy on assessments? Does it only include assessments for those people who are over 75? Some things to go back to your practice and check out. What's your policy? And then, if you have a policy, what's the actual procedure to fulfil the policy requirements? So, once a month, does someone check the recalls? Who puts the recalls in the computer to find out, or the reminders to find out if that assessment's going to be done? Who makes sure once the assessment has been done, the recall is updated? All things that probably need to be listed in your policy document and your procedure document so that you can follow up, so that you can manage your patient cohort better. The policies and the recall and reminder system gets a bit confusing from time to time. Really good way of managing some of those hard to reach patients or big practice cohorts, so that people don't always slip through the gaps. People will slip through the gaps because people like to do that, just to cause us to buy more shares in L'Oreal. I think there's a conspiracy going on. But a way of managing that is to use that recall and reminder system. How do you know when to recall a patient? Does anyone have any idea? Do you go and by what the doctor tells you?
When it flags you.
How do you know when it's going to flag you?
Well, you can search for your you can do a search in your recalls to see if there's due. We use the online system for Health Engine.
Yep.
And it tells you who's due for what recalls, and then you can send out in text message or phone call or letter.
So how does that recall get to your Health Engine?
They have already been set up as a recall in the computer program, and then usually the nurse goes through, sees to see if the assessment has actually already been completed, to see if the recall needed to be changed but hasn't been.
So it's actually not up to Health Engine at all, is it? They just do what someone else told them to do.
Yeah.
Whose responsibility is in your practice to make sure that recall or that reminder is actually in there? For a lot of you, it will be your role. So it's something to be aware of. How are you going to know this is a diabetes patient? They need a recall at this point and this point and this point. This is a COPD patient. They need a recall at this point, this point, and this point. This is a 2-year-old. He's going to or she's going to need a recall at this point for the immunisation. So we have pathways and guidelines to guide us. And I suggest you all do a bit of a Google search. The Red Book, the Green Book from RACGP are a good place to start. Heart Foundation have some good information. Kidney Foundation have some good information for chronic kidney disease. There's 1,000 guidelines out there. There's a book that's produced in Queensland that's clinical guidelines, and it has amalgamated a lot of them. You can Google it and download a PDF. It costs a mint to buy the book, but the PDF is free. And that's a good place to start. There's lots of resources out there to support that, so that you know when you're putting a reminder or a recall in for a patient, that's actually, there's a purpose for it. You're not just doing it because someone thought it was a good idea and they're going to make $36 when that patient comes in. You're doing it because there's a clinical reason to engage that patient at that time. You're trying to keep them well. And looking up those guidelines, being familiar with those guidelines, are you, as a nurse, upskilling yourself, which goes towards CPD points. And don't forget that. You're upskilling, if you do that, you spend time doing that, you're upskilling yourself to become familiar with those guidelines. Record it as some of your CPD time. So we've got all these things in place now. We know what we're going to do. We're going to go back to that preventative care, because a lot of our assessment is to establish what preventative care is going to be appropriate for our patients. So why do we do preventative care? There's lots and lots and lots of reasons. Most of them is to try and keep people weller. And we've decided, that's me and a cohort of my colleagues, have decided weller is a really good word and we're going to keep using it. I encourage you all to join us, because we'd like to sit in the dictionary one day. We've all got aims. So, we're going to do a health assessment. And there's a series of health assessments you can do on various ages of patients under various software templates. And so doing preventative care helps us not only keep people well, but pick up those people who are looking for the gaps, who are trying to slip through, or who are unaware that they're at risk of a particular illness or chronic disease. And most of them are chronic diseases. There's lots of, in preventative care, there's lots of preventative care that's not necessarily for chronic disease, but for quite serious diseases. And the cancer screening is one of them. And the bowel cancer screening is the other one. Is everyone familiar with the screening kits? Yeah? We don't need a demonstration. I'm not doing it here. But I'll take a volunteer. No, I won't. You'll find you have lots of patients coming into your practice with one of these under their wing or in their handbag or in 14 plastic bags because they don't want anyone to know that they poo. Sorry? Yeah, or that they've turned 50. Not yet, they're yet, don't know what it feels like. And they'll bring them in and they'll say, what do I do now? So I advise you all to just familiarise yourself with the instructions because you'll find you have to spend 3 or 5 minutes explaining that they need to poo in a container without any wee. Wipe the thing through it and put it aside, label it, put it aside, get the next one, you know. They can wean them now? Oh, they couldn't wean them when I was teaching them, so there you go. So yeah, just
each kit is the numbers assigned to the patient as per Medicare, so that's why you can't hold spares in the practice. Yeah. Because the one that goes to the patient is that patient.
Just to reiterate for the video, the number assigned, the kit number assigned to each kit is individual, and that has been assigned to a patient's Medicare number, so they don't let you have spares. That's because they're trying to track the effectiveness of the program. It's actually a really difficult one to track because you find, particularly in Melbourne, and Melbourne's got really high rates, a lot of patients are opting for colonoscopy as opposed to playing in their own poo. Trust me, I'm playing in my poo, not doing the colonoscopy thing. But, you know, individual choice. And it's hard to actually track because a colonoscopy is not necessarily a screening tool. So that's one of the reasons that the numbers are linked, so they can actually track the effectiveness of the program. So if they need a new one, you need to actually send them back to contact the information on there so that they can get a new one assigned. It's really good if you can do that rather than just getting the doctor to write out a path form. It's really good if you can actually get them to get a replacement kit rather than, because again, it's very difficult to track when the doctor just writes out a path form for a bowel screening.
Is it something that's only available to over 50s, or if someone's concerned, can they get one, like can they apply
The
for
national
one?
screening is for people over 50 and they're rolling out at the moment that every 2 years you'll be sent one. But there's others that you can do, like in general practice you can go to the GP and there's path ones that you can do automatically. I think Rotary do one called bowel scan, there's no age on that. You buy them in pharmacies. But this one that you get on the national bowel screening is the national bowel screening program, and there's a register attached to it. So it's also good if somebody gets called back into general practice because they've done it. So the general practice might not even know that they've done it, but if they've put the general practice's name down on the details, you'll get the results. So then that goes into your recall reminder system that you should recall them. Then they will go off and have a colonoscopy. When you write the referral for that, if you can write on it that it's part of the National Bowel Screening Program, because then that gets reported. If they're having it at a hospital, if they're having it publicly or privately, it then gets sent back up to the register. So it gets marked next to them. So if they've had a colonoscopy, they won't necessarily be sent one in 2 years, because if the colonoscopy is clear, because all the gastros will say, oh, don't worry, for 5 years, and they go, beauty. So when they get the kit, they just chuck it. But often, if the whole recording system's not followed up, it looks like they've not re-screened again. So it's problematic in that it's a national program that all they provide is the kits, and then it's left to primary care to sort out the rest.
They are pretty good, but because I've dealt with a client that had an abnormal result and they chased the patient, chased us with paperwork and phone calls that they do follow up, because the patient kept refusing, and we're just like, we're trying, and we tried weekly to get her to come and go in for the colonoscopy and get referred on to the general surgeon, but we finally got her in, but it took time.
Time to do that.
Not always ready, and they just keep putting on the back burner.
And that is something I was just about to say as well. They will follow up if they're on the register. You can get it done privately at any time if you are concerned. So the answer to your question is yes. It's not through the screening program though. It's aside to that. There used to be a doctor incentive for completing the referral if they did come back with a positive result. The incentive's still in place?
No, I don't think so. At the moment, the hospitals in Victoria have been given incentives to ensure that patients that are referred to them are seen within 30 days, because some of the waiting lists for public colonoscopies are late. But I don't think that incentive's still in. I'm not sure.
Yeah, I'm not sure either.
A formalised register is meant to be starting along with the cervical screening program, and it's all been delayed. But it is being recorded somewhere. But I'm not sure about the incentives. I won't say.
Because there is a reporting form.
Our practice manager represented.
There still is. I know, because I used to be in the practice I work in, was responsible for making sure those forms got filled in, so the doctor got their $7 or whatever it was. Yeah.
Just wondering if anyone did lose their kit and they came to us, are they able to contact Bowel Screen directly to get it?
Yes, the patient can contact them directly. The number's really easy to Google, but it is on the back of a kit if you happen to see one and you want to put it somewhere in your practice where you'll remember. Good luck with that.
The health department's asked a kit could be sent to every practice, so there's a sample there. Because often for patients it's like, oh, here's that kit, and they don't even open it to have a look, but just have a look and see that it's actually not that scary.
So if you have that population cohort that's heading in that age, and I'm assuming most of us do, a poster in the waiting room can be really effective in just normalising, and that comes back to your population health. So you're conquering two birds with one stone. One poster, population health and preventative health management. Go you guys. Accredited. And accreditation. Three birds, go us. There's other screening that you can do. There's the cardiovascular risk assessment, really easy to do, really easy to find online. The diabetes or OSD risk. Again, another one really easy to do. And good education situations for your patient, just to improve their health literacy. Even if it's just making them aware that their risk is low or high. And then making them aware of maybe one thing they might like to consider to do to reduce their risk. That can go a long way to improving their outcomes and improving their quality of life, which strangely is what we want to do. So the health assessments. Oh look, there was a whole slide about that. Who knew? You can edit that bit out, by the way. The health assessment. Yeah. Mary dropping all the words she shouldn't say. So there is quite a series of health assessments you can do for patients. The schedule is set out there. It's really easy to find. It's on lots and lots of websites. There are requirements for each item number, and using your skills, which are not inconsiderable, to facilitate the GPs carrying out this service is a really wise use of your time and the resources that they have in general practice. GPs become scarce as the further we get out from cities, we all know that, and encouraging GPs to use your time, which costs about a third of their time, helps you with your skills. It helps you with your job satisfaction because you feel like you're able to do something that's valuable. And sometimes at the time when you're doing a health assessment, you're thinking, we did this last year and nothing has changed. But then you'll get the patient that will come through with, oh, I get chest pain when I go to bowls, but I haven't told the doctor about it. And that one thing can make a big difference to that patient, where they haven't told the doctor about it because they go in to see the doctor. It's a 10-minute consult. They've got their script they've got to get, and they've got to talk about their dog, and they've got to talk about that spot that's bothering them on their foot, and they forget that they get chest pain every Tuesday when they go to bowls until you say to them, what do you do for fun and how is bowls? Again, putting the data in the right place is something I can't encourage you to do enough, so that you can go back and compare data, so you can track, has this patient actually changed over time? And if you find out something people put in a health assessment, and something really valuable and really helpful is what the person does for hobbies or social engagement, and putting that into the notes means you have some way of conversing with the patient, making it personal to that patient, so the patient gets buy-in. They think they matter because you know something about them. You've read the notes and you know they go bowling. So if you put in bowling or lawn bowling, can someone please explain what that is? It really confuses me. But there's value in capturing that social information. You know, they have 4 children, but they don't speak to 2 of them. Can be really valuable in your discussions with the patient, but also helpful for social prescribing, which goes a long way to promoting health as you go forward. And we'll talk a little bit about that in chronic disease management. So how can you impact on these health assessments in your practice? Because this education session is all very well and good, and I can spout what you can and what you can't do. But if you can't take it back to your practice and actually make it valuable for what you do every day, you might have a population where 90% of your population is under 4. Not a lot of that's going to help you. But is there stuff you can do in your practice that is going to help you? Do you already have things in place? Share, because I want to learn something too. Please. Do you already have stuff in place?
Yeah, we do searches on through medical director residents come from aged care on patients that more diabetes and chronic illnesses, but I do the CMAs for the doctors.
So you do the CMAs? Cool.
Aged care.
Yeah. Does anyone else do the CMAs? Do we all know what a CMA is? We do? We don't? I'm not getting any shaking. Oh, yeah, I'm getting a shaking of head. Excellent, thank you. CMA is a health assessment or comprehensive medical assessment for residents of aged care. And there's a specific item number you can bill if the doctor does that. There's specific requirements, which I'm going to get into shortly, somewhere. And that means that the patient needs a copy, the clinic also needs a copy. The patient can leave their copy with the nursing home if that's appropriate, to monitor and assess the patients and plan for future care needs. So that's its purpose. So we go on now to the item numbers for assessments. These are the health assessment item numbers. There used to be a lot more. They've streamlined it a little bit. Because there are great demands on the general practitioner in general practice, it's quite acceptable to include the nurse time spent gathering data, outlining issues, educating the patient, supporting the patient in your item numbers. So if you spend half an hour doing a health assessment on a patient and then the patient sees the doctor with your assessment recorded, you can include your 30 minutes with the doctor's 15, which brings it up to a larger amount that the doctor earns. And the doctor likes that.
When you put on the 10997, that's $12. Like,
How much is 5 times 12?
$60.
Yeah. So you get paid, that's an hour of your wage.
Our doctors spend like 5 minutes after a health assessment with them, and we've spent like the 45.
Yeah, so are they billing?
And they, like, I've seen them do like the 60-minute ones
Yeah.
for like 10 minutes.
Yeah, because they're allowed to include your time.
And they're that's,
pocketing $269
but like,
because they've still got to pay.
they're pocketing a lot more than like what I've done.
Getting 70%.
Yeah.
They do, and yeah, there is an inequity. That's probably a discussion for a different day, and I'm more than happy to participate in that with you. Wouldn't it be nice? But there are some ways you can actually combat that. I know in one of the practice I worked in, I negotiated with the doctors. I want a bonus.
Yeah.
If I bill X amount of the 10997s, then I want some of that. I want a percentage, or I want a day off, or I want a meal, or I want an education session. And I did. I negotiated and they paid for me to do the skin cancer medicine course because we negotiated that I would improve their billings of particular item numbers by a percentage over in a time period. I kept really good records then, let me tell you. But those sorts of things are quite valid for you to do and approach your general practice. You might get knocked back to start with. My suggestion to you is keep trying. You know, if I can improve it, can I have a wage rise of X amount of dollars? That might be better for you. I don't know. But I'm more than willing to talk with you about what I did. Because, doctors do get paid more than what nurses get paid.
The way that I see it is it's not also about money, it's about making sure the patients are getting what they require. Because like in our clinic, the doctors don't get the percentage, they get a wage as well. So they're essentially, I feel, co-workers. Our doctors in our practice aren't our bosses, whereas we have management. So, but like, I just look at it as like, you can try and get bonuses, like you said, but it's more about getting the patients in to make sure they're going good.
And that's what I was talking about. The job satisfaction you can get from chronic disease management and from preventative health is actually quite huge because the patients really come back to you and say, that really made a difference to me. And that really does improve. And if you went to nursing to get rich,
but also with a lot of these rebates, like it's great that they include the nurse's time and it can be billed under that one, but we've got to remember too that it's not just going to the GP, it's the insurance of the practice staff and others as well, because we have a lot of that mindset in some of the work that we do, and it's like, oh, these GPs, they're just all after money, and it's like, sure, they live a comfortable life, but but I mean, there's some that aren't as ethical as they should be around their billing, but just to remember that
it's not all about the money. A lot of it is about patient care, and a lot of it's about your satisfaction.
Yeah, I feel like the GPs we do an hour, and it is all about the patient, and they've probably seen them God knows how many times that week already. They do the hard work as well.
We all work hard. I'm not saying we don't. There's actually some really good studies out. One of them was done in Queensland 2 years ago now, almost 2 years ago, 2016, outlining the impact nurses can have in assessment and chronic disease management. It was a small study, I will admit, because it's quite hard to get time to be involved in these things. I forgot to turn my phone off, sorry people. It's quite hard to be involved, to find time to be involved in these things. But I'm sorry, I needed to deflect. But the study showed quite definitively nurses being involved in health assessments and chronic disease management improved patient outcomes, improved patient satisfaction dramatically. Patients were disclosing things that they'd been holding on to for years purely because they had the time and the trust that they built in this nurse. They actually felt like the nurse cared about them, and so therefore would disclose that they've actually had this nagging pain for 2 years, 3 years, 5 years, whatever it happens to be, or there was this issue that they just couldn't get to the shop, so they weren't eating. Little things like that go a huge way to making a difference to your patient population.
Can I just ask a question on
Ask whatever you like.
Sorry, the numbers that were up before. So I'd always, the doctor would bill out 705 for a CMA, a residential aged care. Have they changed?
Yeah, there are different item numbers for a CMA.
I thought CMA was 705. On the Medicare, 707 is not residential aged care. I think it.
I have got a list somewhere. I'll get back to you with the answer for the CMA. health assessment item numbers, because when I was doing them, they were different. But I'll check and I'll get back to you if that's all right. So health assessment item numbers. This slide very, very easily sets out all the requirements for health assessments. If you're not doing all of these things, then you're not meeting the requirements. Which is why GPs find it really, really helpful to encourage the nurses to do the hour with the patient, or the half hour with the patient, because then they know that they're meeting a lot more of these requirements than what they would be, because they're billed on a time basis. So if they have a patient there for 30 minutes, they'll bill a 7.05, but then they'll think, oh, but if I see 3 patients, I can be getting more money. Whereas they can be seeing patients while you see the patient, and they still get their 7.05, and they get their 3 item 23s, which means that practice has more income, which means you get paid, which means you get to eat, and eating is great. So, to meet these requirements, there are software, all the software have templates out there that mostly outline the software. The health department there is a PDF on the health department website that gives you a PDF of a health assessment, but I suggest you just go to your practice software and look at what is in your health assessments. And you can look at all of them, because you can look at them on the online training thing that I showed you earlier, and see, is there something, does best practice set it out in a way that suits me better? Can I get that template and use that and then fill it into my Communicare or whatever software I happen to be using? Does medical director do it better? Or do they frame their questions in a different order that suits my style of nursing? And that's okay to do that, because what you're trying to do is marry up your style of nursing and your style of conversation, which, as you probably gathered, mine is slightly different to most people's. So you want to marry that up with the patient engagement, because one of the things that you really need to do is get the patient to have consent to all of this. If the patient consents, they need to have an understanding. To have an understanding, you need to get that patient engagement. They need to want to know what you're talking about. Because I know myself, if I go to education and I don't really want to be there, I don't learn very much at all. But if I want to be there, lots of things resonate with me, lots of things I want to take away from it. And you get the same from your patients. So what you need to do is marry up your style with what templates are available and with what your patients require. Still meeting the very strict framework that MBS provide. It's not set, you can do it in any order that you like. We had a template set out in one of the practices I worked in that went demographic details, name, age, address, next of kin, what did your mum die of? That's confronting. I've never met you before. How are you today, Georgia? It's lovely that your name's Georgia. Have I got that right? Yeah. What did your mum die of? Oh. Really? Oh, here's another one. Have you got an advanced care plan? Really? So have a look at what you're doing. Have a look at what you're saying. Hey, if you've known the patient and you've done the health assessment the last 4 years in a row, that's fine. If you go do a home health assessment, you knock on the door, they open the door and they say, apple, table, penny. You might need to change things up a little bit. They've been practicing that. So things to consider for your practice when you're doing a health assessment, as an individual as well as for the whole of your clinic that you work in. When you do your aged assessment and you're going out there and assessing dementia, and they know that you're going to ask them to repeat these 3 words, and they're the same 3 words every time, they're going to learn them. They're going to know that you're going to ask them to count backwards from 100 in sevens, and they're going to learn it. And if it's in a retirement village that you do this, they're going to share it. And they
this morning because I look after the old guys.
Yeah.
And that's exactly what they do.
They sit down at breakfast and they'll swap notes. No, it's not 93, it's 94. No, it's not. What's apple table penny? Oh, she used tree on me last time. So some tips for you guys, mix it up. Although, if you do mix up the words and use different ones, it's a really good idea if you remember what they are. Don't know how I know that, okay?
Sitting there going, no, you tell me.
Yeah, there you go. I've got nothing. It's a good thing there's a gap in between you saying them and them having to repeat them back, because it gives you time to think, which words did I use today? If you are picking your own words, and I do encourage that, try to pick unrelated items. Picking chair, table, plate is really closely related and quite actually doesn't give you the information you want to find out from that, which is what's their memory like. Because they're related, they are a trigger for each other. So that's just a tip for young players, or people new to it, you can be whatever age you like, to actually think about what you're asking and how you're asking it, and also the reason why you're asking these questions. You know, if you have a blind person, asking them to read, close their eyes, probably not going to work. Just saying. So think about the reason for it, and can you adapt the assessment to meet the person that is in front of you and their needs as well. What are we looking for in a health history? All the usual things. What's happened in the past? It's a history. But we don't want to know about their phone calls, and we don't want to know about their chest pain. We want to know about actual conditions. I was listening to someone speak late last week, and they were saying they had rheumatic fever as a child. That's probably valid to keep as a history item, particularly if they're going to see a cardiologist or if they're short of breath. But keeping the fact that they've had a ECG every 12 months, that's probably not going to help. Putting in that rheumatic fever as a child, last ECG and the date, and that it was normal, is probably really useful information to have. Because if their last ECG was 20 years ago and they're now 50, might have changed, maybe. Useful information. So think about what you're recording as your past history, and is it going to be useful to you, and is it going to be useful to any other clinicians that see them? Now, I'm not saying include everything, because they don't need to know that I had a cold last week. That's really irrelevant. I've got over it, we've moved on, or last month or last year. They don't need to know that I had a flu vax every year for the last 20 years. They probably just need to know that I had one last year, or last month, or the last one would be relevant in you, including that. Don't forget to include your social history. Social history has a big impact on chronic disease. It has a big impact on health. So don't forget to include your social history. Recurrent injuries is another thing that people can miss, but could be an indicator that something's not right. And your SNAP assessment. Are we all familiar with the SNAP assessment? No? Any guesses? Help me out here. So we've got smoking, nutrition, alcohol, and physical activity. There we go. And thank you, because my alcohol gets lost in activity. Really good thing. The other thing to remember when you are documenting illnesses or current problems is an acronym they call OLD CART. Why did it happen? What happened? How did it start? What caused it to start? So when did it start? How did it start? Where is it? What happens? How did it happen? What's associated with it? How long has it lasted? What's happened? What have you tried? So reactions and treatment. What you plan to do going forward. That's a good acronym to remember. There's lots of documentation about that. I'm not going to get into it in any more detail. So that's your health history. Diabetes risk assessment. There are, again, really easy templates out there to assess this online. Best Practice has one, Medical Director has one, all embedded in their software. You can just click on all the right bits. It will import, if the data is put in the right spot. If you've got a blood sugar recorded in the right spot, it will pick up that it's there if it's been abnormal or if it's been normal. If you have blood pressure recorded in the right spot, in the blood pressure, in the observations, it will pick up that that's been done. If you have waist measurement recorded, it will pick up that that's been done, which makes your life much easier because you're not either scrounging around in the notes looking for where it was recorded because you know someone has at some stage. Also, you're not scrounging around in your drawer looking for the tape measure, and then you've got to get the patient to stand up again, then you've got to wrap the tape measure around their waist, and then you've got to record what that is, then you've got to put it in the right spot in the notes and then go back to your assessment. You could just record it in the right spot in the first place, job done. So this is relevant for your 40 to 49 assessments. You can do it from 40 to 49, diabetes risk assessment, every 3 years. I have got 3 fingers. Who knew? Sorry? 40 to 49, every 3 years, diabetes risk assessment. And it's a time-based, it's a 703, 705 time-based billing. So if you do education around the diabetes risk and what that means for the patient, patient-centred education usually works the best, just a suggestion. Then you can bill, if it takes 20 minutes to do that education, the doctor then spends 10 minutes saying, well, this is your risk assessment, this is what we're going to do going forward. That's a half an hour, you can bill a half an hour. You can do it for Indigenous patients from the age of 15 to 54. There's another item number, and it's always billed as item 715. They should have a plan of what's going to happen next when you do that diabetes risk assessment. Next, working up in age, the 45 to 49-year-old health assessment. We're looking for their risk of developing a chronic disease. So you need an assessment, but you need to include specific things to that age group. So you would do a diabetes assessment, if that's not been done. You would include sexual health, skin integrity, mental health, physical health, their diet or nutrition if you like, and their vaccinations. A lot of people forget the vaccination history or what is coming up for them. It should include, under MBS, if you're billing MBS, it should include some health literacy, so some education for your patient, and what the follow-up is going to be. So do they require any further investigations? Do they require any follow-up? You know, if they're fit and healthy and wonderful, just like I am, then they may not, but mostly they do. Mostly it's recommended that there is some follow-up, because apparently it's after 50 that it all starts to fall apart. But as there's no one over that age in this room, we wouldn't know yet, yeah? Again, for 75 plus health assessments are yearly. So there's one health assessment between 45 and 49, and then yearly once you get over the age of 75. Very well documented that if you can convince your practice that you can safely, you know, stress the safely, go out to a patient's home, we find we get really much more comprehensive results from your health assessment. You learn things like, I went out to see a lady, lovely lady, one day, and she was doing okay. She was struggling along there, you know, living a life, doing what she did, quite happy with her lot in life. And just chatting with her, so where do you keep your medications was one of the questions I asked. It seemed relevant at the time. She said, oh, they're in my little dose thingy. They're quite happy. I keep them here on my table. So that's all fine and good. I said, so when this runs out, do you refill it yourself? And she said, oh no, my daughter does it for me. Great, wonderful. Bit of chatting, bit about the medications, what she was taking, what she wasn't taking. She had a pretty good handle on that. So how often do you see your daughter? Oh, she picks up my scripts once a month. And she brings them here and she puts them in the container. It was a week container. I said, so what do you do with the other ones? She said, oh, my daughter puts them in the cupboard on top of the fridge. And I again asked, do you refill them? She said, oh no, my daughter does it for me when she comes. I said, so you don't get them down and I can't reach that cupboard. So she was getting her medications once a month. I went to the cupboard with the person's permission, opened the cupboard, and seriously, I could have opened a pharmacy. There were years worth of drugs in that cupboard. But I never would have known that because she had a good handle on what medication she was on. She had a good handle on what they did. And according to her, she took them every day till the box ran out. And then her daughter would come back and refill it 3 weeks later. There's no problem with that, is there? No? Yeah, no, I didn't think so either. I did think so. But I never would have found that out had I not gone to her home. There's other things you find out that's really quite interesting. You know, they have 14 cats, 3 dogs and 2 canaries. That was an interesting exercise. And they lived in a house that was essentially a caravan. That was interesting. Others who you're trying to push the front door open, they always come into the practice looking immaculate. You're going out there thinking, this is going to be a lovely visit. You can't get in the front door. So you learn lots and lots of things that really impact on the patient's health by going out to their home. Others will have lots of anecdotal notes about, you know, asking them to see what they've got for dinner, and they'll open the fridge and there's cockroaches crawling in there. That's a Queensland example, not so much a Melbourne example, but still it is something that actually happens. Mice infested.
I've heard a story of a home visit where the lounge room table was filled with supplement medication. Just put your food on top of the supplement medication and keep going.
Yep. Yeah, so did everyone hear that? The patient had all these supplementary medications, all your vitamins, your minerals and all those sorts of things you can buy over the counter or in the supermarket. So they put the meal on top of it, and they just kept going. I actually went to a home visit one time where a particular gentleman, lovely man, and when you saw him outside the home, again, quite well presented, and in his home he read the newspaper every day. I know he'd been reading the newspaper every day since about 1942 because they were all stacked up in his house. And he used to buy TV tables and he'd put his newspaper on, read the newspaper, get his dinner, eat his dinner. The plate would go back to the kitchen. He washed every Friday, so that was all good. He had enough plates to last him till Friday, whatever. And the next newspaper would go on top. So when it got to about here, when he's eating his dinner, he couldn't see the TV anymore. So that table would get picked up with the newspapers on, because bending wasn't really his thing anymore, and it would get moved to the hallway or to the spare room or to the side, or where at this stage now we're wherever there's space, and he'd buy himself a new TV table and he'd start again. Kind of cute? Yeah, I'll agree. So, you know, you spend your money on what you wanted, but that was sort of educational, I thought, like a really well-read man, as it turned out. But little things like that can come out when you do a home visit that you may never know, but actually do impact on the patient and their health. So if you can safely do a home visit, and the practice will support you to do a home visit, I would encourage you to give it a bash. If nothing else, it can be amusing. It's great. Don't forget sometimes other things that impact on health, not only their chest pain and the sore on their foot, financial and social things can have a big impact on their health. And something I'm sharing is this thing, and I'll pass it around. It's our patient profile thing. It's something developed that explained to people that the things that impact on you as a person are not only your health, but there's all these other things that actually make an impact, and they also impact on your health as well, because everything impacts on each other. And that was something that was really, that we've found really useful for helping encourage the patient to become more involved in what's actually impacting on them, so they become more health literate by being able to manage these other things. Little things like, can I get to the shop to get food. You might think that's not their health, but it is, because if we don't eat, I think there's dire consequences. I haven't tried yet. Don't plan on it. Little things like that. You know, if I've got to pay my rent or my mortgage, do I have enough money for food? If I've got to get my children to school, can I use that petrol to go somewhere else, to a doctor's appointment, to a hospital appointment? Those sorts of things have an impact. You know, if my kid's mucking up in school, which means I have to spend more time there listening to the principal tell me what my child has done wrong, I don't have time to get to a doctor's appointment, or I don't have time to get to work to pay the bills so that I can get food. It all impacts, and that's something I'm happy to share if people want to have a look. Little things like that make a difference. So don't forget them even in your older population, your 75 plus. Again, have a look at the on-demand training site that I popped up earlier. Have a look at what they require in their health assessments for all ages, because they've all got different templates, and they will allow you to open it up and have a play in there. And again, you can't break it. Although if you do, let me know. I want to know how. Here we go, comprehensive medical assessment for those in aged care. Again, there are specific requirements. The patient should be offered a report. The report should have recommendations about what has been assessed, and it should be used to inform what care going forward. So used to inform care planning, as we do with all health assessments. It must include the history, it must include any examination investigations, appropriate interventions, and what collaboration is going to be done with the aged care facility. No questions? Yes?
How frequently should a medication review be done?
At the moment, the guidelines say 2 years unless there's been a significant change. The pharmacists only get paid every 2 years, so that's probably a good indicator. I'm boring them? Mm-hmm. All right. Assessments for Aboriginal and Torres Strait Islanders are put in a separate section. Can anyone tell me why? The gap. Yeah, there is a significant health gap with this cohort of our population. For those of you who are unaware, I assume we're all aware, we're all pretty intelligent people here. We've got some stats up there. 24% of deaths of Aboriginal or Torres Strait Islanders in 2013. 24%, that's pretty high. Cardiovascular disease. Diabetes, 5 times the rate. Mental health is obviously an issue. And that's only what was reported, 2 times higher. And that's, again, only what was reported. 18% report having asthma in 2012. That's also significantly higher than the rest of the population. So there's definitely a gap there. Closing the gap was established a while back. I'm not exactly sure when. It's been around since 2010. Yeah. And it's to promote that that closing of the gap, as they call it, to promote healthcare or healthcare opportunities. There's a few things to be mindful of in this population. It may take more than one visit to the GP practice to complete all the requirements of a health assessment for this population. It may require quite a lot of diplomacy on your part in asking the questions that need to be asked to complete the requirements for a health assessment. Having a male doctor speak to a female about their sexual health is a big taboo for a lot of that population. So being mindful of those sorts of cultural implications of what you're doing and establishing your care pathways to facilitate that can really make your job easier, but also make the assessment more valuable because you'll be getting real information. And real information is way more useful. Just saying. Some people are reluctant to disclose their status for a variety of reasons, which I probably won't get into here. But again, being mindful of that and encouraging a disclosure so that you can help promote health rather than because you just want a label to put on someone is probably a better way to do it than saying we just need to know. You probably all figure that out though, I'm thinking. There's a lot of documentation out there, a lot of cultural awareness training that you can participate in, and I would encourage you to do that if you have it available to you. Seeking it out yourself can be quite beneficial. Where's the rest of my slide? Oh, there we go. There's a bit of a definition. I believe this applies to all of our population, not just our Aboriginal population. This little statement explains that Aboriginal health is not just about their well-being, it's about everything that impacts on that, and that's sort of what I talked about a little bit earlier. I like that it says to achieve their full potential, because I actually believe what we do in general practice promotes everyone achieving their full potential, whether it be neonatal care, helping mum understand the behaviours of their newborn infant, all the way through to helping Mavis get to the grocery shop so she can eat. Because if Mavis eats, Mavis can actually function better and look after herself and be happier in what she does. That's maximising everyone's potential. Promoting health prevention measures for someone in their 50s or 40s actually means they can continue working and then look forward to a retirement to do the things they dream of doing. Apparently it's good to have a bucket list. You can achieve your bucket list if you have health. So there we go. It's important to be culturally competent. Asking the question, there are sensitive ways of doing it, and I encourage you to do that, how a person identifies. And then having your policies and procedures in your practice, being mindful of whatever culture comes into your practice, but also recognising that this particular group have particular needs, and focusing some of your resources to these needs may make a big difference in the population health of your practice. Health assessments for these for Aboriginal and Torres Strait Islanders. So from 0 to 14 there's a child health assessment. There are templates usually in your software. For adults you use the 15 to 54. Not all of us are convinced that a 15-year-old is an adult, but their body's heading that way, so we're running with that for the moment. And then the older person for over 55. Thought they were still adults, but what would I know? Again, this is item 715. So there are financial benefits to doing this for the practice. And you must explain to the patient what you're doing and get consent. So the informed consent not only includes what you're doing, but it also includes why you're doing it. The mandatory content is an overall assessment. It includes recommending interventions if that's appropriate. It includes providing advice and information and a record and a copy of it being offered to the patient. The non-mandatory bits are the bits that give you the information. It's your eating habits, your physical activity, your speech and language, your motor skills, your SNAP assessment. Don't forget that if you have an Aboriginal or Torres Strait Islander who has a health assessment, you can build the 10987 up to 10 times in a 12-month period. That is for the nurse to get engagement for the care of the Aboriginal patient or Torres Strait Islander patient. You can also bill the patient is also eligible for an extra 5 allied health visits. So in total they would get 10 if they have a care plan. So don't forget those requirements that may assist your Aboriginal or Torres Strait Islander in achieving better health. It's spelled separate. You do a separate form under the TCA for those of you who don't know, and there is a template in the online training for that separate group of 5 allied health visits. Any questions about Aboriginal and Torres Strait Islander thing? They've developed a really cool flowchart. You can download this. This is one's from Hunter New England PHN or Central Coast PHN. But it does help if you need to explain, go back to your practice and explain to your practice manager, your GPs, your other practice nurses, what you're trying to implement if you are trying to develop a policy around your care of Aboriginal or Torres Strait Islanders. This actually makes it really easy to map out that care and to show other people what you're trying to achieve. As I said, ongoing support, they must have a health assessment, and then they can have the 10 services for billed by the nurse care or the nurse input into their care. And there are other things that are available for those who do identify as Indigenous. They can have their prescriptions a little bit cheaper under the PBS. If they need to get to specialist appointments, there is some financial support available, and they can also access transport to and from health appointments, and for some medical aids there's also support, so have a look for that. The challenges to you to do health assessments in your practice are being allowed to do them, to being given appropriate amount of time to do them, because you can't do an assessment in 10 minutes. I defy any of you to do a comprehensive health assessment in 10 minutes. If you figure it out though, let me know, because I'm going to learn from you. So you need to be given an appropriate amount of time. You need to be given a place to document what you've done, otherwise why are you doing it? If you're learning this new information about a patient or updating information that was already there, but you've got nowhere to record it so that other people can use that information, I think we have a problem. They're the barriers I can see. The only other barrier I can see is your skills, but I am sure that you all went to and did your nursing training. You all learnt about health, how to do a health assessment. You can all take a blood pressure, you can all answer questions, you can all follow a form. So I'm not including that as a challenge. Can you think of any others?
How many interruptions do you get when you're doing your health assessment?
That is a big challenge. How do you combat that?
Oh, I actually start refusing to answer phones and door knocks.
Yeah. And
then I get really grumpy and they just see the look on my face and they know not to come back.
yeah.
And that's the doctors. And
Yeah.
can you come and help me? No. You can find your things in the treatment room. I'm with this patient.
Exactly. Because if you went and knocked on their door when they're with a patient, unless it's an emergency, they're going to say the same thing. Sometimes you have to teach your colleagues to respect your skills just the same as you respect theirs.
They can see your appointment. Well, in my case, doctors can see my appointment book. Like they can open up my appointment book and see that I'm with someone for a care plan or a health assessment, and they'll ring me and go, "Oh, can you do an antibiotic injection now-ish?" And I go, "Well, I've still got half an hour left for this client." And they just go, "Right, hang up," and then they do it themselves and then come and say, "You know that injection that you were too busy to help with? I did it myself."
And you say, "Thanks very much, I appreciate the help." I assume we all have that problem where a GP or another clinician will say, "I need you to do this now," and you say, "Well, hang on a minute, I'm with this patient," and they'll say, "Oh, okay."
I think another barrier is also if the doctor's running behind with other patients and not willing to complete the assessments once you've started them, the patient's been there waiting and wanting to get it done, and then they want the patient to come back.
Yeah.
Especially with the Indigenous community, because very hard to get them back in.
Agreed.
And so you have to get the doctor to get it done on that day.
Yeah. So that's the other barrier, getting someone to the GP, the next level up, to actually look at what you've done as an assessment and complete that assessment. And you'll find a lot of practices have these incomplete health assessments sitting in their software somewhere because the doctor's been too busy or the patient hasn't come back to complete the health assessment. Has anyone got any strategies for overcoming that one?
Going and saying why.
Questioning,
It's
yep.
not the patient's fault that you were running behind with other patients before them.
Yeah.
And it's going to be too hard to get them back. That's one thing we do try and say, and then the majority of the time it works.
Yeah, so explaining that that patient's unlikely to come back. Using the financial incentive is something I've been known to do. To say, if you don't see this patient, it's not going to get billed. And I've done the work, and my time is valuable too.
Potentially educating reception staff if they aren't aware to book the client in for your assessment, and then maybe 15 minutes later booking them in to see their doctor that they did the assessment with.
Yeah, that's
to finalise the assessment as well.
What we do.
yeah. So using a whole of practice approach, and I promote a whole of practice approach. Reception or admin has a big role in allocating the appropriate amount of time so that you can do your part, but also the GP can do their part to complete the assessment. Because the value from the assessment is got not only from what you've discovered, but from planning what care is needed to maintain wellness going forward. The value isn't only in just doing the assessment, though there's a lot of health education and health literacy improvement in that. The big value is from, okay, we've discovered that this is what's happening for you, this is what we're going to do going forward. And that's part of that is the GP's role. Anything else? Cool. I would encourage you to have a look at your recall and reminder systems, your preventative health systems, which are essentially, and have a look and try and encourage people not to add to those lists, because it's very difficult to do a health assessment recall when you've got in your recall system health ASS. The next one is health ASS ES. And then there's health space AS. And then there's health space ASS ES. And you've got now 15 different recalls, all for the 75 plus health assessment. And they all mean the same thing. But if you happen to miss clicking on one of those recall items, guess what? That patient misses out. So I'd encourage you to, whoever's adding to your recalls or updating your recalls, to look at what's already there and do not free type. Because free type, unfortunately, is where we get into these problems.
Archiving old recalls is a good one as well, because you can sit there and there'll be a list of 20 recalls from the past 5 years.
Yeah. Having a look when you open a patient, just as a routine, this is a really easy quality improvement thing you can introduce in your practice. Your practice manager will think you're a god because they have quality improvement tasks they have to tick off for accreditation. If you've introduced one, they can use it for theirs, and so they think you're wonderful. But just doing that as a policy, every time we open a patient, I'm going to encourage everyone, have a look at the recalls that are there. Update them so that they're relevant, and you're not recalling someone that you've been recalling for the last 5 years, and they've actually already had that done, or whatever. So I would encourage you to also do that. And like I said, document it as a quality improvement. You don't need to do a PDSA cycle if you like me and think saying PDSA is a bit akin to swearing. If I hear that again, I might leave. But you can do a quality improvement project by saying, what are we going to change? How are we going to test it? What are we going to do next?
We're developing business rules on that sort of thing as well, so that when any new doctor that comes in or any doctor that uses it, they are not allowed to create a new, these are the ones that you've got to use it from there. You can make your notes elsewhere, but it's not to be changed, and there's no free texting.
Yeah, and I would encourage you to do that. We used to cheat and say, oh, best practice has done an update. Please don't free text because it might not be saved. I didn't say it wouldn't be saved. I actually said it might not be saved. And so saying that meant we had a huge change of behaviour in the doctors because they didn't free text. We told them they could free text in the information box and under in best practices, you pick your diagnosis from the list, and most things are covered in the list, but let's be realistic. Then in the box down below, you can put your other information. And we found a lot of uptake in doctors when they were doing that. We got better information, so we've put in COPD, we put in their last FEV1 was whatever, 45. In the clinical notes, that was saved as a history item or in a recall item. They didn't add anything new, which meant our data searches were a lot better. So we just said, oh, it might not update, and they believed us. We transferred over from medical director to best practice and said the same thing. Oh, in this program you can't. And no one came to us and said, but I need to add whatever, pick a disease, SHU, as a disease, because my patient's got SHU and there's nothing that matches. No one ever came and said that. They actually found something that it matched every time. Something to consider. These here is a list, and hopefully you have the slide of the list of useful information and useful websites. Most of them are MBS online. There are a couple of other websites. If you're looking for something specific, just doing a search under what specific, you'll find a lot of PHNs have put out information on that particular topic, particularly around assessment and chronic disease management. We all seem to reinvent the wheel each time. So have a look for that if you are looking for more information. Or you can pester me. I'm more than happy to share my brain with you. But I actually suggest we all get a cup of tea or coffee. Yeah?
Yay!